I have Dr. Yahea Alhagawi, consultant gastroenterology from South Hospital, Military South Hospital. You're going to speak about new and old hemostasis. Thank you, Dr.
I think we have some technical problem. Anybody from?
We need audio visual here, please. We need audio visual.
Okay, sounds okay. Yeah, it's okay now. Okay, Bismillah ar-Rahman ar-Rahim, wassalatu wassalam ala Rasulillah. Hello everybody and good morning for everybody. I know you are feeling tired after Dr. Abdurrahman lecture, and my topic will be short and easy, inshallah. First of all, I would like to thank the organizing committee, Dr. Abdulaziz, Dr. Abdurrahman, for their great effort to organizing this workshop and to give me opportunity to sharing with my colleagues. My topic today, it will be about old and new endoscopic hemostasis. And as an introduction to my topic, as we know that the endoscopic hemostasis is one of the greatest and very challengeable technique that must mastered by every endoscopist and gastroenterologist in his daily practice. And because it is very essential for the management of acute gastrointestinal bleeding and also for the prevention of the bleeding during the high-risk endoscopic procedures. Historically, there are three groups of devices or methods that have been available, either by the injection therapy, which is the oldest technique and usually involves the injection of epinephrine and other sclerosing agent, or by the mechanical therapy with clips, loops, or band ligation, or by the thermotherapy, either using of ABC and bipolar or monopolar probes. And there are several new endoscopic hemostasis technologies that have been developed over the last years, in part because of close collaboration between the international experts and the industrial companies, like self-expanding metallic stent, hemostatic forceps, hemostatic powder, and over-the-scope clips, which are currently being used in the endoscopic hemostasis. I will start with upper GI bleeding. This one also can be used in lower GI bleeding in a patient with non-portal hypertension bleeding or non-variceal GI bleeding. The injection diluted epinephrine in a concentration 1 to 10,000 is available worldwide and achieve hemostasis through a combination of compression, vasoconstriction, and the platelet activation. And it is the easiest treatment method because it does not require direct viewing during the injection and may be used when the tip of the scope is angulated or retroflexed. If epinephrine is used alone, there is a risk of high risk of the rebleeding, and to avoid this risk, the combination therapy with other hemostasis therapy or with large volume, it can reduce the risk of the rebleeding. Second hemostatic therapy, we are using hemostatic clips, which was established tool. It used to control the ulcer bleeds or the possible lobotomy bleeding. There are various models from different industry suppliers are available. And the clipping is the easiest when the endoscope can be maintained in a straight position with ability to push it axillary into the tissue. As I mentioned, there is different type of clips in the market, and the clips differ according to their reopening capacity. It is rotatable or not, jaw width, and the cost of the clips. In one meta-analysis published in GUT in 2007, showed that the dual endoscopic therapy was clearly superior to the mono endoscopic therapy, and also showed that the superiority of the clipping versus an epinephrine injection alone, but not versus thermocoagulation. Thermal therapy usually involved in the use either of bipolar probe, which allow for superficial coagulation. It is very useful for the injected lesion, but there is a risk of perforation. The injection gold probe from the Boston Scientific, it is a multifunctional device that allow for the performance of thermal therapy and the injection with a single catheter. I don't want to go through the electrosurgical. Dr. Abdurrahman, he spoke about it in this one thoroughly. But as he mentioned, okay, for the electrosurgery, either we can use the monopolar, we can use the bipolar. Also, we can use the ultrasonic devices, or we can use as a laser therapy. The choice between the mechanical or thermal therapy in association with the injection of epinephrine will depend on the localization and the characteristics of the lesion, the skill of the endoscopist, availability of the tools, and the nurse training. And as mentioned before, there are different electrosurgical units that are available in the market, and each hospital have own electrosurgical unit. And as Dr. Abdurrahman, he said that, okay, he advised every unit to have one brand in the unit for the electrosurgical. Now I'm going to talk about the topical hemostatic agent. They are new tools. It was used in the endoscopic hemostasis, and there are 3 different powder are available. The first one is the hemospray, and the second one is the uncovered blood stopper, and the more recently the endoclot. Hemospray, it is an inorganic powder that was first utilized in addition to the standard gauze to control the external bleeding in the military personnel, especially in the Second World War. And the powder has 3 mechanisms of action. It will form a mechanical barrier over the bleeding site, and it is absorbent and act as a serum separator, which increase the concentration of the clotting factor, and it also electrostatic due to its negative charge. The second one, it is the uncovered blood stopper. It is a traditional Turkish herbal mixture that has been used for hundreds of years to treat the various cases of the complex bleeding. And unfortunately, it's only available in Turkey, and its exact mechanism of action is incomplete understood until now. The third one, it is the endoclot. It is a polysaccharide hemostatic system. It is the latest available hemostatic powder in the market. And according to the supplier, it is intended for use as an adjunct hemostasis to control the bleeding from capillary, venous, and arterial vessel in the gastrointestinal tract. Its composition is very simple. It consists of starch. That's why it is worldwide is available, especially in Europe and Southeast Asia. The other modality for the hemostatic therapy is using of the over-the-scope clip system, or OTSCT. Recent endoscopic devices, it was primarily developed for the endoscopic closure of perforation or fistula. And in the clinical data on the endoscopic hemostasis with the over-scope clips are promising. And in one study, more than 140 patients have reportedly been treated with a clinical success rate of around 95%. Hemostatic forceps, it's usually used for the prophylactic or curative hemostasis during large interventional endoscopic procedure like EMR or ASD of superficial tumor with low rate of rebleeding after usage. Now I'm going to talk about the bleeding lesion related to the portal hypertension. As we know that esophageal varices considered to be the most frequent etiology of the bleeding in patients with bleeding lesion related to the portal hypertension. And in the past and historically, until the development of the endoscopic and the pharmacological therapy, bleeding varices were managed using the balloon tamponade. Band ligation is considered to be the gold standard hemostasis to control the esophageal varices bleeding. There are different types in the market from different companies. In patients with type 2 gastroesophageal varices and in those with isolated gastric varices, injection of the cyanoacrylate or tissue adhesive like histoacrylate or globranto It will represent the treatment of choice and give the best result in terms of hemostasis, rebleeding, ulcer scarring, and mortality. Thermal therapy, particularly ABC or argon plasma coagulation, are the treatment of choice of gastric intravascular ectasia. It can also be used for the angiectasia and the post-radiation bronchitis with a good result. So in summary, endoscopic hemostasis has grown in parallel with the number of devices available for the endotherapy. Hemostatic powder, over-the-scope clips, hemostatic forceps, and other emerging technology have changed daily practice and offer diverse possibilities to stop the bleeding. Endoscopic hemostasis is obviously an inherent part of the management of bleeding. So management of the bleeding, it is a cycle starting from stabilization of the patient and using of the pharmacological medication. We can start endoscopy to control the bleeding. The best combination for endoscopic hemostasis should be obtained the highest rate of hemostasis while minimizing the rate of the rebleeding and adverse events, and at the end be easy to use it in all locations and try to be inexpensive regarding using the hemostasis therapy. Thank you so much.